Good afternoon, everybody in Ethiopia, and good morning for those of you from the US. And this is our series on coronavirus 2019, the webinars trying to communicate both ways to prepare the healthcare professionals in Ethiopia, organized by the Ethio-American Doctors Group. And today we have a special friend who's lecturing and giving his thoughts on issues of leadership around this pandemic. Dr. Daud Siraj is a graduate of Jimma University. He's a faculty member in the Division of Internal Medicine here at the University of Wisconsin with the rank of full professor. He is a director of the University of Wisconsin Health Clinic. He serves also as an associate director for infectious diseases fellowship program. He was a public health trained, tropical medicine trained, and internal medicine boarded. He has been instrumental and participating actually in all the activities that are happening on the ground in Ethiopia in preparation of the pandemic, working very closely with the Ministry of Health. So his presentation today on emergency, challenge, and leadership is going to be a critical component of our message and preparation for this pandemic in Ethiopia. And I just want to welcome my friend and neighbor, Daud, to give you this 30 to 35 minutes presentation. And Daud, without any further ado, the floor is yours, and thank you for being here.
Thank you very much, Girma, for that really kind and nice introduction. Good morning, everybody from Ethiopian side. Thank you again for being here, and good afternoon, I mean, from Ethiopia, and good morning here from US. As you can see my slides, I titled this talk as Emergency, Challenge, and Leadership, because really we're in an unprecedented time, as you know. We're in an emergency, very challenging situation. And really our leadership and collectively, everybody's leadership is really highly thought and needed, as you see here in US. Failure of thereof is causing us such a disaster, as you can see. So the objectives of this talk are going to be three basic things. It's just about sharing what I have thought and processed throughout these 2.5 months of working on coronavirus, sharing the lessons learned from heavily affected countries and highlights of the importance of decision-making like a central command, and then emphasize the critical elements of pandemic preparedness. And when we talk about all this, we should not forget how we got in here. It started in China, in Wuhan city. And around December, when nobody knew about this, when this was a business and a problem of a single hospital, Dr. Wenliang, an ophthalmologist in that hospital, actually noticed this, looked at those patients who are being quarantined in that hospital and look at their outcomes, and tweeted actually in his social media, not tweeting, in his social media, wrote something like this. He said, a disease which is really unique, which looks like SARS, which is the older cousin of this disease, is emerging. So everybody who is coming to this hospital should wear their masks, their gloves, and be ready. This didn't go very well in China, and the China government at one point, actually, they imprisoned him for disseminating false lies and rumors and scare. Eventually, he was released. Unfortunately, he was doing surgery in a glaucoma patient who was not diagnosed with COVID-19, and eventually got it and died at the age of 34. The lesson of this should not be lost in all of us. Pandemics and epidemics are not the business of a single hospital. It's not a single country, even, for that matter. If we were to act collectively at that early stage, we wouldn't have been where we have, with trillions of dollars lost and so much damage and life lost in this world. So as you know, for a brief introduction and to bring us all to the same plate, let's briefly review what this the biology of this disease is. COVID-19 is the seventh identified human coronavirus. As you know, the traditionally known common cold, gunfan and actually is caused by coronaviruses in 40% of the time. But they were benign. They just caused simple cold. People got sick for a couple of days and get okay. They don't have to go to hospitals most of the time. It was not until 2002 that we saw one of these mutant coronaviruses, which we call it SARS, that was lethal, causing a lower respiratory tract infection as a complication and causing pneumonia. But the good thing is that virus didn't have had a very critical component that is needed to cause epidemics or pandemics, and that is transmission from person to person. It was very poor. Because of that, it was easily controlled without any draconian mitigation measures. This was in 2002. Around 2013, another virus from the same group, MERS-CoV, emerged in the Middle East. This also was deadly, but transmission was very, very poor. But these were really sentinel events, warning signs for us that we never recognized and prepared. And now we are confronted with this COVID 2019. It is very closely related to SARS, but more importantly, it is closely related to SARS-like virus that circulates in mammals, specifically in bats. And this virus was known since 2005. People knew about that, looked at it, but there was a critical biology component that was lacking, which is it doesn't infect humans. But as you know, viruses multiply in millions and billions every day, and they have a selective advantage of mutation, and some of them are detrimental, those mutations, but some of them gives them a selective advantage, and that probably is what happened. And it jumped from bats to humans. But unlike the SARS, this virus actually had that critical component fulfilled, which is the transmissibility from human to human was very high at around 2.5, which means basically every single one who is infected on average without any control measure will infect about 2 to 3 individuals. And so that logarithmic transmission that we see every time. In very early times of this disease, around January 27, and you will see how this disease is really logarithmic. Very early, when it was really in Wuhan city, in that Hubei province, there is a university in Hong Kong who actually collaborates with WHO, brought this, actually summarized the disease pattern and propagation in such a way. It's an old paper, but I just want to show you what the predictions are. Sometimes, you know, we always talk about predictions in the future, and we forgot how many of them actually were right after the time passed. So this is a very difficult slide, so I will show you. On the right side, the numbers, the y-axis are actually numbers of confirmed cases outside of mainland China. So it includes all of us. And then on the left side is the number of confirmed cases in Wuhan, mainland China. And you can see around, even at the end of January, which seems really far away years back, but it was only 2 months and a half back, 3 months back, there were only 90 cases outside of China at that time. But they make it in such a way to show you that how the logarithmic growth would look like based on the transmissibility of the disease. And this is kind of a busy slide, but there are very few important points to summarize on this one. So the R note that you see that everybody talks about is the transmissibility. In China, it was around 2.13, but once it jumps to Europe and America, actually we're looking at it to be close to 2.5 and 3. And that has a lot of consequence, because how many individuals will be secondarily infected? So this is a virus coming into a naive population, no vaccine, no treatment. You introduce it in that population, and how many secondary cases will be built? And the doubling time is the time it takes for it to double. So within every 6 days. So that's why for the first few weeks, you see this slow trickling without intervention. Remember always that without intervention, because if you intervene, you are kind of tampering this logarithmic scale grows, and that's what you want to do also, and that logarithmic scale of doubling might not be manifested. So at that time in January, when this paper was published, those scientists say that based on its trajectory and transmission capability of this virus, close to 75,000 cases are already in Wuhan. That's what they estimated. But China was reporting less than 6,000 cases. And this is probably what is what the reality is than what China was giving us. Wuhan city is a central city in the central area of China, as you can see here. And once you have 75,000, no control measure is being done. The government is trying to control the PR campaign. You can imagine how many people have got out. In fact, the challenge was coming. People were seeing that Wuhan might be closed, shut down. So people were really running around, getting out of this city. And to just give you a highlight, 13.5% of all outbound air travels from China actually arises from Wuhan to the world. So you can see how many people can move around. In fact, at that time, it was estimated that by the time the shutdown was, the lockdown was introduced into Wuhan city, close to 6 million people already have fled that 11 million densely populated city. So based on that prediction, what they say, those scientists is, even if there was a lockdown, since the number is so high already, and people have been really fleeing this city, there will be a big epidemics within China and also outside. The one thing that they didn't predict very well was the epidemics within China. Again, there is a lot of debate going on this one, because people think that China didn't give us a full report. But most importantly, we saw how China reacted. In every city, there was a mini lockdown if there is a case. So they actually tampered with that logarithmic scale and that spike. But for us, all of us who really ignored it, like Europe and America especially, who didn't do the whole business of epidemic control and the mitigation programs, we are seeing it as it happens exactly what, only the time is basically what is different. So why are we even talking about coronavirus? Because unlike the other viruses that we have been seeing, it causes lower respiratory tract infection, which is pneumonia in many of them. In fact, this is a small study. There are many studies nowadays. I don't want to go to the science because that was not the purpose of this talk, but just to show you one of the studies, early studies, almost 74% had bilateral pneumonia from those infected, and about 17% has ARDS. And you know exactly where it is leading to you when you have ARDS, and about 75% of them needed some form of oxygen. In fact, about 13% needed ventilation. So when you look at this, you can understand what the challenge could be coming into our country. This is another study, 138 cases of hospitalized patients in Wuhan again. And what is the message is about 26% of those patients actually received an ICU care. Mortality was high, and ventilation proportion was also high. So when I see this kind of data, which has been actually replicated all over the world as it propagates from Italy, Europe overall, and again, US. That is what worries us when it comes, when it comes to Ethiopia. How are we really handle this disease? Because our ICU capacity is very, very limited. So really leadership would be really at the forefront. When I say leadership, because there are a lot of choices how to tamper and mitigate this graph. Ethiopia's purpose, and in general, all of us, wherever you are working, practicing, your purpose should be on how to dampen this graph. We would do much of service to our society by trying to affect that rather than trying to upscale our hospitals as important and as good as it is to meet the demand, which is really very huge. So when I say a comment, so everyone who is at a leadership position, a hospital administrator, a hospital medical director, or maybe even a regional director, has to start thinking about how to organize a command center where every information is processed and actually put in a way that can be deliverable to every hospital so that they can actually perform something. And the command center must include the highest levels of political leaders, because there are some very painful decisions to make, and unless they are on the table, it would be very difficult to implement those. Regional health office leaders, hospital administrators. I know there are not a whole lot of infectious disease doctors, but any doctor who is willing to take up this responsibility, whether it's a medical director or being designated the head of corona response team in every single hospital. And interestingly, also religious leaders, because some of those decisions, like, for example, closure of mosques and churches, will not be implemented unless they are signing into those kind of decisions. So we were talking about the command center and the members of that command center and how it should be organized, because I want everybody to understand that in this day and age where the information can be received in different ways, we need to have a uniform message to healthcare workers and the public at large. So all decisions should be centralized and uniform in this command center. All questions and challenges that are coming from the public and the medical professionals has to be channeled into this command center and got a response appropriately. So once you have the command center established, then you are going to start actually addressing the critical challenges and the responsibilities that are there. And the first one is really testing. You hear everybody, including WHO, saying aggressive testing, and testing. And it is not without a reason, because unless you know the magnitude of the problem that you are in, it will be very difficult to plan, because the command center's one main task is really to plan ahead. So we really have to challenge the system to give us a testing capability. If you are in regions, if you are in a hospital, you have to have a mechanism on how to do testing at a regional level so that to generate the data, or also at a hospital level. So that is the biggest critical component of this command center. You would start, when you prioritize those who would be tested, of course, the first ones are going to be the contact tracing results. You have a single case, you have contacts around that case. These are the high priority, high value for your money, because the likelihood that you would get a positive is very, very high. The second one, especially once the epidemic is in full speed, once it is once an understanding of community transmission is really fulfilled, then everyone who has upper respiratory tract infection with fever or pneumonia in your hospital's ICU care should be considered for testing also. So these are the two main components. And then if you don't have enough specimen just to really define the size of the problem that you're having, like at the beginning in Ethiopia, we didn't know how big this problem is, and we did almost 641 high-risk asymptomatic patients, like cases like airport workers, cab drivers, hotel front people, and things like that. just to see if there is a widespread underlying epidemic. So every city, whether it's Bahar Dar or Awasa, if you don't have any idea about what is going on, this kind of test in a very selected individuals in a sample would be very helpful to know really if there is any underlying disease going on. If you don't have that capacity, at least start by simple measures. Because at the end of the day, why are we afraid about coronavirus? Because it is giving us a severe form of pneumonia, which ultimately kills a significant proportion of those individuals that are getting sick. So every single hospital and regional office have to start collecting data on the last maybe a month, 2 months, or 3 months on how many patients have been seen with a severe form of pneumonia, how many of them died, and if there is any pattern difference from last year or 3 months before or something like that, just to have an idea. If that gives you really a significantly disproportionate increase in pneumonia cases, then it is worrisome, and you have to go to the next step, which is basically testing, okay? Once you have started testing, and once you know how many patients you have to start creating the worst and best case scenario for your own locality. I don't like the models that are being done in a country base, like in Ethiopia or any other country, because we have been lucky that we are in the last phase of this round of epidemics movement, we're getting ready before the disease actually reaches our borders. We're doing that right now. We're organizing ourselves, we are preparing ourselves. So the likelihood that this disease will just blow up in the country at every place at the same time is very unlikely. It is going to be city by city, area by area. So for every region, we have to have some kind of modeling where we see and estimate what the capacity need will be at the peak of that disease propagation. So this is done by models. There is no other way. And as I said here, all models are wrong, but useful, very useful. You cannot plan without a model, but you have to understand that all models have so much fault. Because the reason is not because it is not a very good science. It's actually an excellent science. But the model is as good as the data that you are feeding it. If you don't have a good testing, for example, if you don't know how much of cases are actually in the community, creating a new cluster of epidemics in your society, the data that you're feeding to this model is going to be wrong, and then the output will be also wrong. So you have to revise your model oftentimes. But more importantly, you can actually modify the model, and that is one of the purposes of the command center. What do you do? Well, the first thing is prevent new cases from establishing cluster. What does that mean? You prevent cases like the way how we are doing it in Ethiopia and as a country. You know, every flight is a risk. So everyone who is coming from those countries have to be quarantined, have to be looked at properly. The screening has to be implemented. By doing so, you will interrupt the potential cluster from happening because you're holding those infected individuals before they arrive into the society. So that mitigates that graph. And this is one of the ways to dampen actually that graph. Screening and contact tracing has to be scaled up. I cannot tell you how impressed I am with those different models that we are doing for Ethiopia, depending on how much screening capacity there is in one region versus the other region. If you improve your screening and contact tracing, this is the pure and simple field epidemiology work. And this is one of the things that you have to do right now to improve your field epidemiology work in every corner of the cities that you are. They have to be ready to deploy in a moment's notice when there is a case. If you were to improve your screening capability from 50% to 80%, you almost half the amount of cases that will be emerging from each contact. And this is really an unprecedented amount compared to what you can do once the cases start to arrive. Then once you have isolated cases, you have also to have quarantines for those who are coming from, who are exposed and who are not sick, like the way how we are doing it in the airports in Addis. So if you are, for example, in Bahar Dar or Awasa, and you are in the command center and you're really brainstorming, one of the things that you have to start thinking is, what are we going to do for those individuals who are coming from Addis? Because that's the only way you're going to get it. So do you quarantine them for 14 days, keep them in a special place, or do you follow them on a daily basis by calling them on wherever they are? So some kind of system has to be created. And the social distancing, everybody has been talking about it. It's very easy to say, but difficult to implement. From closure of universities and schools to religious sites, working at home, and all those things. Basically, you are trying to, again, affect that curve by creating distance among each of us. Because, as we said, this is a disease that is transmitted from person to person. And if that sick person is not being exposed to people who are potentially susceptible hosts, that virus will die in its natural course, whether that person is going to be cured or even he might die, but nobody else is going to be generated from that one. The hand hygiene, obviously, you know it. And one of the other mitigating factor is mask distribution. There is so much being talked about masks. I mean, the science behind it, it is droplet, it is aerosol, forget about all this. Mask will help. The problem is, the question has to be how much? That's the only question. And in a country like ours, where we have very limited options, I think I'm a very strong advocate of universal masking. It is not the health standard masks that we're talking about. This has to be reserved only for medical professionals, but just any cloth mask that we can do to society. So once we know all those mitigating factors for that graph, we have to work on them, because that is the way how we're going to drop the number. And the second thing is, we have to know when to trigger the model. So people do an exercise of modeling, and then they present to you with that model. But if you don't have a community transmission going on right now, that model is not going to be triggered, because the model is telling you when the peak of this disease is going to be, for example, 2 months from now. So if you just start it today in January, around March, you will have a peak. But if you don't have community propagation, if you don't have a full-blown epidemics going on in your place, that model should not be triggered. So you don't know when you're going to start it. It is an exercise that is waiting to very useful in the future, but you shouldn't trigger it. So for example, in Ethiopia, if you ask me, no single model is going to be good at this point in time, because I really truly believe that there is not a whole science to show us that there is a community transmission going on at the epidemics proportion, at least. So the biggest one is going to be the field epidemiologists. Airport screening is very, very critical. Contact tracing, you have to work hard, very hard, to include health extension workers in your region, to include low-level medical professionals on how to do contact tracing and quickly isolate exposed individuals when that time comes, when you have a case in your country or in your city, in your hospital, and things like that. And you have to start working on places to isolate those patients. Where are you going to put them? Where is the quarantine site? So quarantine is for people who are exposed, no symptoms. For 14 days, the incubation period, you just put them somewhere, see who is going to be sick. The ones who are sick are going to go to the hospital. The ones who are not sick, after 14 days, they go out. Isolation is for those who are already positive. So these are the two places where you have to have. And then after, one of the issues that we have seen in, whether it is in Europe or in US, is actually people come in to be tested because they are sick, and they actually transmit this disease within our hospitals, within our compounds. And this can happen really easily in Ethiopian setting also. So one of the work of a command center is going to be, once this epidemic is fully in your city, think about creative ways of doing the testing. Can you actually select very small health centers, or maybe even new places where you are designated, a medical professional is sitting there with the equipment, to collect specimen, because they don't have to come to your hospital and potentially expose people who are in the waiting place, medical professionals, and things like that. Okay. The other pressure area is call center. Once you have the epidemics, as we saw it in Addis, the moment the first case was seen, a lot of people actually want to know about the disease, how it is transmitted, how many cases do we have, what do we have to do to mitigate this. And a lot of calls are going to come and people don't know where to call. So the command center's responsibility is to create immediately actually a call center. You have to train briefly, even non-medical professionals to answer those calls. You can give them really cookbooks about the answers. Most of the questions are going to be very simple about the disease, or where should they go if they suspect that they have the disease. Do we have anybody in our neighborhood? I mean, these kind of questions have to be answered for the society to be at ease and cool down. But more importantly, also, when people who have symptom calls in, they will be the ones who will be telling them where to go to be tested, and also maybe warning those sites beforehand to tell them that somebody is coming to be tested who is at high risk, who has all the symptoms. So get ready, have your mask before he comes in, and all those things, you know. And if this disease really goes in a full power, like the way how we are seeing it in Italy or in US, hopefully it wouldn't be like that. But if it happens, we would be triaging patients. Which hospital has the ICU care? Which hospital is taking care of those patients who are not really sick? So those people can actually play the role of triaging of those patients when they call to that place. And these have a very significant role in dropping actually exposure and subsequent number of infections that can be created from every single case. Okay. Another work of this command center is really organizing and creating a message for everybody to share. So a daily meeting of the leaders really would be sought. Not today, because you don't have a case maybe, but eventually when this is really in full-fledged, when the epidemic hits you, you really have to meet on a daily basis to review and evaluate how you are working, okay? And within those meetings, you have to talk about those things like equipment. How good is your hospitals equipped to handle this? Do you have oxygen supplement? If you don't have oxygen supplement, is there any access actually for oxygen for your hospital? Can you buy oxygen concentrators? What can the Ministry of Health do? What can donors do? All those things. How many ventilators do you have? If you have a ventilator, if you don't have, that's okay. Okay, but you have to do an inventory at a region level, at a hospital level, and at a country level, so that you would know when someone is asking you, you have to have all those informations at the tip of your finger to plan ahead, to plan for the future, okay? Another thing is personal protective equipment. This is one of the biggest issues because as medical professionals, we are always confronted, especially in an epidemics like this, with being exposed, not only being infected, but taking this infection also to our home, to our loved ones. Medical professionals have been seen to be transmitters of this disease in a community. So this command center has to always look at how much of those equipments they have, which one has to be refilled. If there is money, which one should be bought, you know? And if you don't have any means, is there any creative means of actually creating those equipments? Or, I mean, almost every city now have a big university, as you know, in Ethiopia. Those Department of Engineering, they're not giving classes nowadays. They have to be creative. Yeah, we have to challenge them to create things. Our garment factories, the same thing. Can they create masks, at least for the universal mask for the public? You know, one of the garment factories that we approached actually said they can produce 50,000 masks every day. So these kind of things have to be started to be taught in that command center. Really, the perfect answer should not be the enemy of the good. Whatever you can get is better than what you don't have. So for example, face shield. I just did my face shield at home, very simple. So if those engineering departments are taught how to do those things, they would produce for us, for the hospitals and the health centers who would be in the forefront of those areas. And one of the biggest tasks of the command center is really to look at their manpower also. How many physicians do we have? How many nurses do we have? How many field epidemiologists do we have who are going to do the contact tracing, the isolation, follow-up of those patients, the quarantine? So based on the amount of people that we have to start being creative. How is the best way to really ration those very limited scarce resources, and how do we protect them from being infected? Because the moment somebody is infected, he's out of the system for 14 days at a minimum, and you're losing that person, he or she. So in some places, they're entertaining about 2 weeks rotation. So what it means is basically they designate a hotel or a place to stay, and physicians, nurses, respiratory therapists, every medical professional will be assigned for 2 weeks. They would not go to their home. They go from the hotel to the hospital, minimizing movements and going to their loved ones. And then in 2 weeks, they will be relieved and another team will come in. Is this a better way for us? I mean, every answer should be looked at by the command center to really appropriate those kind of human resource limitations. Do we prefer to have a dedicated COVID team so that there will be experts over a short period of time, and they can actually minimize risk of infection and transmission, and there will be experts also on how to handle. If we have very few cases, that might be a reasonable approach, but you have to have a option plan B, because if you have so many of those, you cannot have dedicated COVID teams for every hospital. So the command center has to create different scenarios and have different answers for those scenarios to respond. Of course, as you know, gloves, gowns, masks, eye protection, these are the things that the command center have to really have done an inventory, communicate with Ministry of Health, figure out exactly how to get them, how much they have, how are they going to share it, and all those. So one of the biggest scarcities is N95 mask, as you know, and this is one of the masks that one of the Ethiopian textile factory produced. The command center also has to work on hospital surge plans, because you're going to need a lot of plannings within your hospitals. How many ICU beds do you have? Which hospital would be designated best for ICU care? Are you going to admit or isolate patients with mild symptoms? Maybe for level 1, you might have to do that, but if you have, so you have to have different types of plans. But if the number is too much, probably you might ask them to stay at home, like the way how we are doing it here, and only come to hospital if they are sick enough to require hospital intervention. So we have to work on hospital decompression also, because other diseases are also going on. Where are patients going to be treated? Where should they go? Who is going to be the physician? How would we appropriate medical professionals to those two priorities that are going at the same time? Look at your prison also, because of the nature of prisons. These are incubation grounds once epidemics goes on. So, you know, there are a lot of things that are going on in Ethiopian setting, so work on that one also. Another thing that we have to think about is about burial on morgue. People, this is a brutal disease. People are dying alone and they are buried without their loved ones. And you might be the last one to see them. So if that is the case, what should we do? The command center has to start thinking, maybe video recording of their last minute, maybe, you know, some kind of communication with family, communication with telephone and things like that. So the command center has to have some kind of plan. If the epidemics goes out of control, there might be time where we have to think about lockdown of cities. Very draconian measure, really, that disrupts the whole activity of a city. But we have to really be very cognizant about its limitations also, because these are based on models, and you can see what is happening in US and everywhere else. The first thing that I want to tell you, and that I've been trying to emphasize with everybody who can listen to me, is you cannot plan for a lockdown unless you have a community transmission. It is not because somebody else in your neighborhood, a city or a state has said, we're going to lock down, that you continue to lock down. If you don't have a community transmission, why are you even locking it down? When are you going to release it also? Because every time you lock down, you're going to say, you have to say, the command center have to say, these are the criteria that we want to see before we ease the lockdown. So it has to be the last resort, if you ask me, okay? Unless you're seeing really clusters going on in a city, a lockdown is not going to be very much effective, especially in our scenarios. I mean, the non-essential gatherings definitely has to stop. Political gatherings have to stop. We have to use a lot of masks. We have to use hand hygiene. But in terms of the day-to-day transaction of people, hospital activity, work, it might be the last ones. And we have to try to do everything else before we go to that resort, okay? So we have to control our message again. As I told you, the command center's job is one of them is to control message. So sometimes I call Ethiopia, even physicians, and they'll tell me, we don't know what is going on. This is it. If you control the message daily, repeating it with mass medias, with your own briefings, everything, in every social medias, people are going to start trusting you because you will be the first one to tell them of everything. And that is actually what the Ministry of Health is doing nowadays. I mean, nobody will be faster than the Ministry of Health to tell us how many new cases there are. And that's a good thing. So over time, people will start to rely on those new media, and they will be that would be the first place that they will be going. So at every state level, you have to start creating those kind of areas. So as a summary, what I said is because lockdown bothers me so much in Ethiopian context. First, it is very difficult to implement. Second, it would be very devastating economically. So everything that we do have to start thinking that can we do everything else without the total shutdown and actually avert these pandemics. This is what we have to start thinking. And by that, I mean, if we do those four things really at a maximum level, I truly believe that we have a chance to do a very good job in terms of controlling these epidemics and mitigating these pandemics without really these draconian measures. And these are, we have to test widely, we have to know the problem, we have to have a very good field epidemiology work for contact tracing and isolation. We have to quarantine people who are coming from infected places, including from Addis, if we are in the regions. You have to adopt a universal face mask strategy. Everybody has to have a mask. If we were to do this, we don't have to go to this closure of shops, closure of things that are really of significant consequence in our economy. But we also have to be ready to really close a city or a neighborhood if a full-blown outbreak goes on. But until that happens, the city lives in. And as a last slide, I want to tell you this. This should be an opportunity for the medical professionals, the medical infrastructure in general, really to come smart and convince politicians who are the coffers and the money distributors of the country to believe that health system matters. We're talking about ventilators and oxygen supply in a country where there are very few of those. And the reason is because it has been underfunded and it was not the priority of the system. And this is an opportunity for us really to lobby to the health, to the politicians, that money really matters and our hospitals really are security risks. So there is a window of opportunity for Ethiopia in general and also for every local, because the transmission at this time, for me, there is no community transmission that I see, okay? And if we do all those things really well, we can succeed. When prevention succeeds, you don't see its results. because, you know, you avert a disease, so what? If it is only when it fails that the magnitude and significance of prevention and early strategy really gets magnified. And this is a quotation that I found. This is a car racer who lost actually a car race. He was expected to win. And he was interviewed and they asked him, why did you lose this car race? Because he was a front runner and everybody was saying that you're going to win. And he said, the most expensive mistake I ever made was hiring a chief engineer, because he didn't put what is needed at the forefront. He didn't win. And if we don't put everything that we can right now in preventing, averting these epidemics from happening in our country, we are going to pay really heavy. So that's the message that I have. Really work hard in those field epidemiology, screening, contact tracing, isolation, quarantine, and the likes. With that, I think I would stop. And if there are questions, sorry about that, guys. I went a little bit longer.
Well, you know, thank you, David. I mean, a lot, very exhaustive discussion in all aspects, be it from the preparation, from the pathology, the epidemiology, you name it. And I think, you know, there's a lot of questions which I want to get to right away. A lot about, you know, testing, and there's also a lot about, you know, community versus non-community issues. So the first question is, you know, what is the role of rapid antibody testing in countries like Ethiopia? Is it even feasible and possible? And the second, you know, something that goes along with it is, you know, what does aggressive testing mean, and how feasible is it in Ethiopia? And so I think maybe once you do that comment, I would like to ask Dr. Wendosen to also maybe share his experience, you know, from testing perspective and the feasibility on the ground, and educate us a little bit where things are. So David, could you?
Yeah, I want to shout out to Wendosen. Thank you for coming, Wendosen. So a couple of things maybe Wendosen might add on that. Antibody testing basically is not a diagnostic test. It's not for acute testing, treating, and isolation. As you know, antibodies, it takes about 2 weeks actually for anybody to produce an antibody. So by the time you produce an antibody that is detectable, which we don't know whether it's neutralizing or not at this time, you are already out of the circle of fear that we call it, whether for your own life or for transmission. It has a very critical role though in countries like Ethiopia, where a lot of people think that there was actually a circulating viral illness in the last 2 months or so leading to these epidemics. If that is true, really, the only way to answer it is by antibody testing, universal antibody testing in a segment of the population. By doing so, if, for example, we were to find like 25, 30% of our population actually has an antibody, we know for sure that this disease has got into Ethiopia somehow, but for some miraculous reasons, it was not deadly because we didn't see it causing our ICU beds really overwhelmed. So that is the purpose of antibody testing, to really do an epidemiologic survey of the population. I think it has a utility in Ethiopian scenario because a lot of people wonder, rightly, because we have so much connection to China, you wonder why we were not even hit earlier than what it is happening. When I say aggressive testing, the main things are these. The first one is everyone who has symptoms of upper respiratory tract infection and pneumonia with fever has to be tested, especially once you confirm that there is a disease going on. Like, for example, Addis Ababa is a case in point right now. The second one is everyone who is identified by contact tracing has to be tested. Then in quarantine, so you have to stratify those patients. The first one is the contact tracing and isolation. The second one is symptomatic patients. The third one is probably quarantine. The fourth one is if you don't have any idea about what is going on, like for example, in Awasa or Bahar Dar, you want to know what is happening, maybe in high-risk individuals, 700 of them, 800 of them, maybe even 500. You do a test to see really, it's not a very good, there are so many caveats on that one, but it will give you an idea about what is going on.
Dr. Anderson, do you want to add anything? You know, you are muted, so we can't hear you. So do you want to add anything?
How about now?
Yeah, we can hear you. Yes,
yes, we can hear you.
Just to add a few points on what Daud has already said, you know, we have severe limitation in terms of our testing capacity because the venues are very limited. But recently we did a mortality survey, you know, by the public health, by the School of Public Health. You know, we have an ongoing program assessing, you know, the diseases at different burial sites, and we compared, you know, the events, the deaths events in the last successive 4 or 5 months. There is no increase. And also we have, you know, to some extent reviewed our hospital data in terms of patients admitted with severe pneumonia, dying from severe pneumonia, and actually there is no increase from what we used to see before. So it all indicates that we still have local transmission and maybe cluster of cases are being built up. So I am not convinced that there is community transmission in Ethiopia now. So the epidemic, you know, the accelerated phase hasn't yet started. We need serological tests, particularly for healthcare workers and people who have really engaged in having contact with the community. Because if the serology test is positive, it indicates directly or indirectly that the individual is immune. So if the disease gets worse, these are the kind of patients who can give sera for convalescent, convalescent sera administration is another modality. So these are some of the points which I would like to add on what Daud had already said. Thank you.
Yeah, so Daud, there is a question about, do you really think the Ethiopian way of screening is working? And then the other question that comes with it is, I think this was a question which is, very elaborated, but to summarize it, it says that in Ethiopia, it was said that in late March, this thing started to go up and the peak should have happened in mid-April. So do you think in Ethiopia it has been flattened in terms of the curve being flattened, and so are the mitigation strategies working?
Yeah, these are very important questions, and anyone who listens to me in social media has to again listen to me here. As poor as we are, and at a small country as we are, compared by any of the other countries, even US and Europe, our mitigation, our strategy to control this disease in the early on was much better, honestly. When I came to Ethiopia in February the 4th, I was there. At the airport, I was screened for fever, and everyone who has fever was separated. There was a place, and it has increased in activity and quality significantly in February. And right now, you know how things are going. In US, at March 15, there was the last flight from Spain, and people came into this country and nobody asked them anything. There were so many people who were coming infected from different countries. So really, I think that has worked. The biggest hurdle and headache for me was the Ethiopian Airlines flights. I always have been talking about that. And now that it has significantly decreased, it has helped. The biggest thing that has helped is the quarantine that has been created. Look at the number of cases and where they are coming from. Almost everybody that is coming from is from the quarantine side. Can you imagine if we didn't have had a quarantine for the last month or 3 weeks of the time, what would have happened right now? I mean, every one of them would have gone to their community. It takes 5-6 days before they start to show up symptoms. People will have invitations, dinner parties, this, that. Exactly the case of Bahar Dar tells you a lot. 500, 600 people would have been exposed for each single one of them who have been contained in the quarantine. So I think we are working really well. It could have been better. So of course, always there is a room for improvement, but I think it is working really well. And we have to emphasize when people say, oh, we don't have a disease, they just shut us down and all those things, because I heard somebody saying this yesterday, and I was telling him because of the airlines quarantine, that's why we are like this. A lot of countries who started with us in Africa have double and triple numbers compared to Ethiopia. Of course, our testing capacity was not as big as that, but by and large, that is one thing. So when you look at Ethiopia, I cannot say even we have flattened the curve. What I would say is we haven't started the curve. We have not started the curve, because every day we are seeing 8, 7, 10 patients, and a lot of them are actually coming from quarantine where they haven't exposed as much people. They might have exposed 1 or 2 of their neighbors within the quarantine, but they were not in their community, exposing hundreds of people. So at this time, that's why I was saying none of the models have to be deployed at this time, because we don't have an evidence to tell us that there is an ongoing community transmission that needs modeling of forecasting. So I cannot say in 3 months or in 5 months, the epidemics, the peak might not ever happen if we continue the way how we are going.
Dr. Wondersen, you want to add anything to this?
I don't have anything to add. Daud has said it correctly. There is no community transmission. From the evidences that we have now, there is no sustained or in order to say, uncontrollable community transmission in our setting. There isn't.
Yeah. So there is actually one of our participants asking, how do you explain those who don't have any travel history and cannot trace? And the other question that comes around lockdown, and there is a question about, should we lock down Addis and contain this from going to the other cities? And in fact, there is a concern, say, from the south, where they think for the last 2 weeks there was some kind of containment or lockdown. Now it has been eased. So what are your thoughts about lockdown of Addis, and how do you explain people who have no travel history coming up with this diagnosis? And I think because of time, just let's make the answers a little bit shorter so that
Very
we
good.
can.
So when Dosen gave me a word, sustained community transmission,
Yes.
Remember that. There can be 4 or 5. Those people would have started community transmission, but we are acting properly, the way how we have to ask, immediately identifying them, isolating them, so that they will not transmit in the community.
Daud, actually, because we are not, do you hear me?
Yes.
Yes, yes.
The connection is really bad in my
But we can hear you. We can hear you.
Because we have not been testing as needed. In order to say community transmission, the background is there should be, this is in a setting where you test.
Yes.
And
so that is the limitation exactly that you said, but with caveat, up to now, with the amount of numbers that we tested, and we actually tested, as you know very well, 641 high-risk patients.
Majority are negative.
Yes, 641, 100% of them were negative, high-risk patients. So yes, we could have doubled and tripled our testing, but with the limited testing, we don't have sustained transmission. Even if we see community transmission, for a community, for a person who is identified in the community to be the instigator of a big community widespread outbreak, you should sit without isolating that person. So that is
absolutely
the reason.
Because it's the tip of the iceberg. If we had such a sustained community transmission, several of it, the hospitals by now would have been overflooded, and our death rate, it hasn't yet increased.
Yes.
We assessed at the burial site, at the Christian and Muslim burial site, as well as in the hospitals. In Kurambasa, the death events haven't really increased. There is nothing different from what we used to see before. So it means that
the maximum that can be done, said is maybe the disease might have been there, but it is mild form, and that I am willing to take that risk. The second question is about lockdown.
Yes.
I just want to say a few words. When you don't have community transmission, really sustained community transmission, please don't lock. Do everything else: contact tracing, testing, quarantine, isolation, mask, universal face mask, everything, but don't lock down. When are you going to open it? Okay, so you don't know where you're going to open it, so don't lock down. Do everything else, and really look at the curve. Before the curve is coming, you cannot lock down a city.
So I think, you know, there are a lot of messages today that has been shared with everybody. However, I really don't want everyone to leave with your guards down. So this is a disease and a problem that requires sustained vigilance, and everybody being very mindful and careful that it doesn't take much to loosen up your awareness and your strict guidelines to completely get into a situation that can be uncontrollable. So I really want to emphasize, you need to still have your guards up. You need to still be concerned that the pandemic can hit, and in your communities, you know, want it or not, you are the leaders. And as Dawood mentioned, the important thing is that you need to have a system, even if it is a very small community hospital, as to how you are going to be organizing yourselves. And Dawood mentioned a very important word towards the end of his talk about COVID teams. So that may sound like you know, something difficult to do. However, I really do think in every hospital here, at least in the US, there are COVID teams. There are individuals who don't have any choice. They have to be part of the team, particularly those who are in the emergency department and those who are in the critical care unit. However, others need to really be on their side and work with them to help them, because the emergency and critical care people cannot by themselves manage this pandemic if it hits, you know, Ethiopia. And so everybody should really be ready to think about and work towards how they can be useful to those physicians. The other important piece is, if you have teams that are already organized and decided, you can actually prepare them well. You can protect them well so that the disease can also be contained. If you have a continuously rotating individuals coming through, say, a COVID unit, you actually put a lot more healthcare professionals at risk. So it's always better to have teams that are ready. It's like going to war. You cannot just take anyone from the street and put them, you know, give them a uniform and put them in the war front. You really need to prepare your soldiers who are going to be well-trained and well-equipped so that they can protect themselves and protect everybody else. And so with that, I think the team issue is important. Every institution will have to do their own calculations in terms of how they organize their teams, but it is unfortunately a critical element that some volunteerism has to be, and some, you know, physicians will have to be leading that team. I think with that, probably we could work on this specific topic of team building and how the teams work, maybe when we discuss in the question sessions tomorrow from the field experience. And I want to really thank both Dawood and Dr. Wondosen for being on this call and giving us an outstanding presentation and remarks. Thank you, everybody, for your questions, because your questions were really on the mark. We will continue the conversation tomorrow. And if we change the platform, change from Zoom to another platform, we will make sure to send you an email, and please then share that email with your friends and colleagues. So tomorrow the presentation is going to be by Dr. Futsum Xavier from Lyon, France, and she's going to give tips and practical tools from the French experience as she was a lead person in her hospital organizing the teams combating COVID-19. So for today, thank you for being here, and see you tomorrow, and thank you again.